go ahead and get started. Hello, everyone. Thank you for joining us. My name is Camille Almada. I am the co-founder of the Anal Cancer Foundation. We are so excited to have Dr. Van Morris here with us today to discuss the role of circulating tumor DNA in the management of patients with anal cancer. My name is Camille Almada. I am the co-founder of the Anal Cancer Foundation. As a note for my disclosures, I'm an employee of Mount Sinai as a nurse practitioner. In this role, I'm involved in various studies, including a study with Natera and 1440 Foundation. Anything I say here today only reflects my own personal views and does not reflect any views of my employer or any of the studies that I'm associated with. So I'm happy now to introduce Dr. Van Morris. He is an associate professor in the Department of Gastrointestinal Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston. His clinical practice focuses on the treatment of colorectal and anal cancers, and he has written multiple clinical trials which incorporate novel therapeutic approaches involving targeted therapies and immunotherapies. His work has been featured in publications in the New England Journal of Medicine, the Lancet Oncology, Cancer Discovery, JAMA Oncology, Clinical Cancer Research, and the Journal of Clinical Oncology. His research has been supported as a recipient of the ASCO Young Investigator Award, NIH NCI K-12 Award, Khalifa Scholar Award, the Swag Hope Foundation Award, and NIH NCI Colorectal Cancer SPORE Early Career Award, as well as a Sabin Family Foundation Award, a CPRIT Individual Investigator Research Award, and most recently, an NCI R50 Award for Clinical Scientists. He is currently the co-leader for the HPV Moonshot program at MD Anderson. So today he's going to speak about circulating tumor DNA technology and the role in the management of anal cancer. And this will be followed by a Q&A. So during the session, feel free to put messages in the chat and also in the Q&A feature. You can submit anonymously, and we will ask those questions at the end of the session. So without further ado, I will go ahead and pass the session off to Dr. Morris. Thank you so much.
Perfect. Well, first of all, just wanted to say thanks so much to the Anal Cancer Foundation for allowing me to represent the MD Anderson team. Where circulating tumor DNA is something that we've been very excited about for the past decade at MD Anderson, and have put a lot of work into bringing this, in the clinical management of patients with anal cancer as well. So I'll be talking today specifically about the role of circulating tumor DNA in the management of localized anal cancer. I think due to time restrictions, may not have as much time to talk about the role for metastatic patients. But I just want to kind of start, like we give a lot of talks, and always just kind of want to make it fun. So I've gave a talk a couple of months ago on anal cancer at Yale University, and I've started deciding I wanted to use ChatGPT to create figures. So I asked ChatGPT, I took a picture of myself that I found like on the MD Anderson webpage. I uploaded it into ChatGPT, said, here's a picture of me. I want you to make a cartoon of me giving a talk on anal cancer to the Yale Oncology Department. And this is what came back. And I just kind of looked at this and said, well, maybe this doesn't look like me. I don't think this looks like me. Maybe it does. You can be the judge of that. But now I've decided that for every talk I'm going to give, I'm going to continue to see what ChatGPT will create. So in prep for today's talk, I said I want to give a talk on the role of circulating tumor DNA in the management of anal cancer to the Anal Cancer Foundation. And this is what came back. So I yeah, again, you can be the judge of whether or not, but I'll take this picture, and so yeah, I'm going to be talking about circulating tumor DNA and the management of anal cancer. So again, thank you for having me here. These are my disclosures that you can see here. I just want to, before I speak, want to say this is not going to be a talk about me where I'm going to tell you you should ask for this circulating tumor DNA. I'm not going to be comparing the circulating tumor DNA assays which are out there. I think it's a little bit premature, but I will kind of hope to really provide some information. First of all, just an overview. What is circulating tumor DNA? What is this technology that I keep hearing about and reading about online? What does this mean? You know, for a diagnosis, I've been diagnosed with localized anal cancer. What, you know, how can I use this to help understand you know, the state of my cancer after I've completed chemoradiation? And ultimately, and most importantly, you know, how can we, you know, apply that knowledge to do better for our patients and hopefully help to cure, you know, even more patients? So I'll be kind of talking about these 3 points over the next 30 to 40 minutes or so. So to kind of start off, for circulating tumor DNA, what is this technology? So just again, to kind of set the stage, you know, anal cancer, you know, is a cancer for which we're seeing more and more, you know, patients being diagnosed year after year. And if you look at the past 20 years, for both male and, you know, female, you know, patients in the United States, we're seeing this, you know, alarming rise in the incidence of anal cancer year after year, despite the, you know, the availability of the preventative, you know, HPV vaccines. For this, I think, as we'll talk about, is relevant for designing circulating tumor DNA specifically for virally associated malignancies. There are certain HPV types which we know are especially linked to development of cancers like cervical cancer, anal cancer, head and neck cancer as well. HPV 16 by far is the most common, but there are other ones that we see as well. HPV 18, 31, 33, 34, 45, 52, 58. These can be some of the other ones that can also cause non-HPV 16 associated anal cancers. But really, the vast majority of anal cancers are driven by and linked to prior HPV infection. You know, we estimate that, you know, probably 90 to 95% of the cases, this is true. So, you know, we can really take advantage of this fact to design, you know, appropriate assays to best help, you know, meet the clinical needs of our patients with this disease. So, you know, again, just a little bit of a background. You know, the Nigro regimen, looking at chemoradiation with 5-FU and mitomycin, that is the most common, you know, regimen given as curative intent chemo radiation for patients with localized anal cancer across the United States. This regimen has been present. You can see 1974 was when this paper is published. So literally a half a century, 50 years ago, this paper was first published. So this is a regimen which has been around, you know, a while, and most patients in the United States who are diagnosed with localized anal cancer will receive this regimen. At MD Anderson, we do things a little bit differently. We actually give radiation with cisplatin and 5-fluorouracil, and we break this up into kind of weekly dosing. And this is work that that Dr. Emma Holliday, one of our radiation oncologists, had published from the MD Anderson experience several years ago. She led this kind of great effort looking at this, and what we saw was that, you know, among patients who were diagnosed with localized anal cancer, there were patients who received 5-FU cisplatin in the arrow that I'm kind of, the mouse is over, and then 5-FU mitomycin. But when you kind of look at these charts, there was no difference in the survival outcomes, you know, for these patients, whether they got 5-FU or mitomycin C. We did see other differences though, and those were in terms of toxicity. So patients who got 5-FU mitomycin C were more likely to experience treatment breaks because of complications that were incurred during their treatment. In this series of almost 500 patients who had been treated at MD Anderson over a 15, 20-year period, We also saw that with that 5-FU mitomycin, there were higher rates of GI, bladder, and skin toxicity, as well as hospitalizations as well. And in one example here, you can see that 50% of patients had major bowel, bladder, or skin toxicity with 5-FU mitomycin, less than a third with the 5-FU cisplatin. The other thing that I think is important to realize when we're starting to talk about treatments moving forward later in this talk is rates of immune suppression, neutropenia, and lower white blood cell counts was almost 10 times higher with 5-FU mitomycin than it was with the 5-FU cisplatin treatment that we're giving. So I want you to kind of hold on to this thought. I'm kind of setting the stage now by talking about the foundations for anal cancer and how this could impact how we design trials and how trials are likely to work moving forward. But we have to be thinking about how standard treatments affect our patient's bone marrow, because if we're thinking about immunotherapy trials, if they don't have intact immunity, we may not be able to help them just, before we even begin with things. So this is kind of just highlighting some of the differences in the treatments of localized anal cancer. But again, by far and wide, most providers are to recommend 5-FU mitomycin with chemoradiation, and certainly it's kind of listed in the NCCN guidelines. So this is, again, I just highlight really when we look at treatment over the past 50 years, it hasn't changed significantly as much. Chemoradiation is able to cure most patients with anal cancer who are diagnosed with localized disease. But again, a lot of the risk factors that when we're meeting with patients, we can counsel them on of if you're at higher risk for your cancer coming back, if you have a larger primary tumor, if you have lymph node involvement, if you're a male patient, these are clinically higher risk. But I think there's room to do better. We really can take advantage of the evolving science to, I think, forecast better and more accurately if patients are likely or not to have their cancer come back after they finish chemoradiation. So hopefully I can convince you, in this time that circulating tumor DNA is really making strides in improving and shifting that paradigm for better, and more accurate treatment for our patients. I think one of the challenges as well is that, if the cancer does come back after chemoradiation, the standard of care is surgical resection, and that often in most cases involves removal of the anus, the anal sphincter, which results in loss of continence and a permanent colostomy. So we started to, at our institution to start looking at the biology. What is the difference biologically in untreated tumors that were eventually cured by chemoradiation versus untreated tumors which were not cured and came back after chemoradiation? And I just want to highlight two fantastic pathologists at MD Anderson I've had the fortune to work with, Dr. Sharia Hernandez and Dr. Luis Sola Soto in the Department of Pathology. But they did some great work kind of profiling these tumors and showed that there are specific pathways which drive anal cancers in patients who are more likely to recur than in patients who are subsequently cured. And it's this kind of information that can help guide and direct us as we think about future trials that are scientifically informed. So kind of with that foundation, chemoradiation is the standard of care. Most patients are cured, but we need to do better in forecasting, patients whose cancer is likely, to come back, with the ultimate goal that if we can accurately identify those patients, can we offer them therapies and hopefully cure even more patients? So that's where I think circulating tumor DNA technology is so exciting. So what is circulating tumor DNA? So basically, all of our cells in our body, as they die and kind of turn over and just being normal cells, kind of dump their contents out into the bloodstream. And then the body kind of scavenges those products released into the bloodstream, recycles them, and then generates new cells as well. So cancers do this as well. Cancer cells divide they die off, they dump their contents, and then they make more cells, and they just do it more quickly, and that's why they're cancer, and not normal cells. So we can take advantage of the fact that there are unique components of tumor cell DNA that's different from the normal cells in our body. And if we can identify those tumor specific fragments in the blood, that can be a surrogate that there is cancer still, present in the body. So we can use these what we call liquid biopsies, a blood test, really taken from the veins of patients, with their routine labs, to draw and assess for circulating tumor DNA. And this is really, I think, outside the scope of today's talk, but we're really have been publishing in colorectal and getting into anal cancer as well, using this liquid biopsy, this blood sample, to identify tumor-specific features beyond just the DNA. So things like we call methylation, fusions, RNA, other scientific aspects that can inform on the biology of our patients that we're able to obtain from a blood draw. So this is a powerful technology. I think we'll be talking about, in the next couple of slides, what this looks like in patients with colorectal cancer, where I think is probably the solid tumor that's most advanced in using and incorporating this technology. But I think this is true for all solid tumors. So we really need to be having these conversations about how we're using circulating tumor DNA in the clinical care of patients, and in future clinical trials as well. So circulating tumor DNA can be kind of used throughout the treatment, or the evolution of cancer, depending on which stages what we're talking about. Today, we're really going to be focusing on patients, again, with curative intent, or patients with localized anal cancer who are treated with curative intent, where we can assess circulating tumor DNA for detection of what we call minimal residual disease. So kind of microscopic levels of cells that you may not be able to see on a CT or PET scan, but that you can detect in the blood, and can be an early surrogate that, hey, maybe the cancer isn't all, left behind. This can also be looked at in the metastatic setting as well. Certainly you can monitor changes in circulating tumor DNA levels as a surrogate of response to, chemotherapy, immunotherapy, or other systemic therapies. And again, that's, I think, beyond the scope, but I'm always happy to talk about that offline or on a different time. So, so if what we're talking about today is, a patient, has, let's just say, been diagnosed with stage 3 anal cancer. They've completed their chemoradiation, and they come back for that first assessment 3 months after. What do we need in a blood test to be able to tell us, hey, is my cancer gone for good, or do we think that, there's a possibility it may come back? So we're using this blood test. What we care less about what the result actually is of the test, because what we really care about is the status of the cancer. And is the cancer going to come back, or is it not? And the blood test is the surrogate that we have to help best inform that. So, ultimately, what we truly want is that the minimal residual disease, the remaining cancer cells, they are truly gone. That patient is cured, and we want a blood test that matches up and is concordant with that. Alternatively, if unfortunately the cancer hasn't been cured and there is residual cancer that's left behind, it's important that we're able to get a blood test that can accurately reflect that as well. What can start being problematic, as you can imagine, is that a patient truly is cured. The chemoradiation cured their cancer. It is never coming back, but we have a blood test that says it is. That can create a lot of understandable anxiety for patients, their families, and for us as providers as well. Oh no, this isn't gone. What are we going to do? The blood test is telling you this, but in actuality, it's not correct. So we don't want false positives. There's reasons those can happen from the test. But we also don't want a false negative. You get that blood test at 3 months. The test showed that the blood test, the circulating tumor DNA is cleared. all is good, where in reality the cancer does come back, and that's an unwelcome surprise that nobody wants. And there's reasons that can happen as well. You can get these false negatives in terms of that can not accurately tell you the cancer is coming back, and there are reasons that can happen as well. When you draw the blood test, if a patient develops metastatic disease in colorectal cancer, if it's in the lung is not often as good for releasing tumor DNA into the blood for patients with colorectal cancer. So sites of metastases, and then assay performance as well. And again, I'm not going to be comparing circulating tumor DNA assays directly today, but these are things we have to be thinking about. So these are more technically called, the specificity and sensitivity, the turnaround time as well. We don't want to be waiting too long to get these results back, because if there's a potential to act on this, would want to know that sooner rather than later. So and there are there are different tumor there are different approaches to these technologies as well. And we'll be kind of talking about the tumor informed versus tumor agnostic. And I actually am a believer that for patients with HPV associated cancers, a tumor agnostic approach may be the more personally the one that I prefer to use. So that's a little bit of background on circulating tumor DNA, and exciting technology. But how can we use this to forecast whether or not a patient's cancer is likely to come back? And before I go into the data for anal cancer, I kind of mentioned earlier that colorectal cancer is, I think, the most developed with regards to solid tumors in general, with use of circulating tumor DNA. And you can see here, these are various studies, and 3 different studies here, over 25, almost 3,000 patients with localized colorectal cancer, where various studies have shown that if a patient has no detectable circulating tumor DNA and maintains that status throughout their follow-up period, their cancer is much less likely to come back than patients who have detectable circulating tumor DNA, where if untreated, there really is an inevitability that the cancer will come back. So we know in colorectal cancer that, again, like if ctDNA is and remains negative, fantastic, that patient is likely to be cured with no evidence of remnant cancer. Whereas if positive, then there's residual disease left behind. So this is a disease that is cured by surgery. If I have surgery today for my colon cancer, in 4 weeks from now, I can check that my blood, and if I have detectable circulating tumor DNA, that prognosticates whether or not the surgeon did or did not get all of my cancer out at the time of surgery 4 weeks ago. One of the challenges for anal cancer, in applying that laterally to anal cancer, is that patients with anal cancer, by and large, are not treated with surgery. They're treated with chemoradiation. The radiation lasts for 6 months after, it just kind of stays in the system and works against the tumor for up to 6 months after completion of therapy. So do we need to be waiting that entire 6 months before we can, make that call on whether the cancer is likely to come back according to the circulating tumor DNA status? These are kind of questions that we'll talk about later, but again, shed light on why this is a different clinical situation than a lot of the other settings in which you may have read about circulating tumor DNA online. There are a couple of other risk factor kind of clinical challenges with circulating tumor DNA for anal cancer that I don't think apply as much to colorectal cancer. One of them is that there's a low tumor mutation burden. So we published on this 7 years ago now, but other groups have shown this as well. Anal cancer is not characterized by a high number of mutations. So a lot of the colon cancer circulating tumor DNA assays, they're what we call tumor informed. So they sequence the tumor for that particular patient. They identify what mutations that patient has in their tumor, and then they create an assay around those mutations to see if they can pick those up in the blood. So you get kind of a personalized ctDNA assay based on your particular mutation status. And anal cancer has a lower tumor mutation burden. So when we're talking about the need to identify, microscopic, levels of residual cancer, I think some concern, that tumors that are characterized by low tumor mutation burden may be more difficult, for detecting circulating tumor DNA and minimal residual disease accurately. But again, this hasn't been compared yet head to head. I think it's more of a theoretical concern. There's also the challenge that, when you do this sequencing for patients with colorectal cancer, you're getting, a large, sample of tissue that's been surgically resected. As we all know, that anal cancer is not one that's surgically resected up front. These patients, our patients are treated with chemoradiation, so we're not getting this large piece of tissue necessarily to do a lot of this analysis. And then, as we talked about earlier, the timing. When do we test patients as well for circulating tumor DNA, given the fact that the curative approach is very different than a lot of the other solid tumors. So when we start looking, this is why I think that, when you're talking about a tumor that's characterized by HPV infection in, 95% of cases, we can, the question becomes, can we identify HPV DNA in the blood and use that as a surrogate for detection of circulating tumor DNA? And when we do that, we get around really all of these, all of these kind of clinical challenges. So various groups have looked at these in kind of small numbers of patients. This was the first published about 6 years ago, looking at 18 patients with anal cancer. And what they showed was that there was detectable HPV ctDNA baseline. And when those patients went through chemoradiation, most of them cleared it, at some point in their follow-up period after chemoradiation. However, there were some patients who had residual circulating tumor DNA, and these are the patients whose cancer all came back. So a small series, but some signal that when you look at two HPV types, HPV 16 and 18 in this study, it seems to be that you can, forecast whether or not a patient is likely to have their cancer come back. This was work that was done out of Denmark, where they looked at the kinetics and the kind of the change in percent of HPV ctDNA over time, and showed kind of similar results to that as well, where they kind of quantified the kinetics of how quickly the ctDNA was clearing as a function of response to treatment. One of the ones that we get asked about a lot in the clinic is NavDX. This is the commercially available HPV ctDNA assay, which is Medicare approved for HPV positive oropharyngeal cancer. To the best of my understanding, NavDX has not been approved yet by Medicare for patients with anal cancer. And we don't have any approved ctDNA assay, to my best knowledge, for surveillance for any assay, tumor informed or tumor agnostic for anal cancer as of yet. But NavDX, this was a study that was presented last month in San Diego at a conference, but they looked at 5 HPV types, and they basically showed that they were able to detect, HPV ctDNA in 85% of the patients that they looked at, and that when patients cleared that after chemoradiation, that they were more likely to have their cancer cured with a longer, what we call recurrence-free survival. When the cancer did come back, though, on average, the ctDNA was detected 2 months, 59 days before the cancer ended up showing up on a PET scan, a CT scan, or endoscopy. So I think the data are very, interesting and promising here, and certainly are consistent with what we're seeing in other cancers as well. We asked 10 years ago in 2015, when I was a first-year faculty member at MD Anderson, we asked a industry partner to create an HPV assay for us, and they politely declined. That wasn't their priority at the time. So one of the amazing things about getting to work at an institution like MD Anderson is you get to work with people who are much smarter than I am. And one of those is Dr. Maura Gillison in the lower left here. And she and her team created a 13 type HPV ddPCR assay. So in a prior one, I talked about 5 HPV types. This assay created by Dr. Gillison has 13 HPV types, and what we call the limit of quantification. So, how low can we go in detecting the presence of residual cancer cells? Dr. Gillison's assay is able to go as low as I have personally seen among the data that's been publicly released out there. So we had the fortune of working, with her and her team, and had amazing patients at MD Anderson who were coming and getting their standard therapies, who are willing to join with us in this mission to say, we believe in this assay, we believe in this approach, but we need our patients' help to analyze their blood over time to see if how this looks. And we this is what we did. We looked at about 65 patients with stages 1 to 3 anal cancer who were treated with chemoradiation at MD Anderson, and we collected their blood at baseline, at the end of their treatment with chemoradiation, and then every time that they were coming back for either an endoscopy, a proctoscopy, or imaging studies as well. And we were able again to take advantage of this very low threshold for detecting, for reliably detecting HPV ctDNA. And one of the things that we saw was that when we looked at patients who had detectable HPV ctDNA at baseline, these were patients who had higher stage, like so the anal cancer itself was larger. These patients were also more likely to have lymph node involvement. And of course, with that, that meant that their stage when they came at their initial diagnosis was higher as well. And this makes intuitive sense. If the tumor is bigger, it's more likely that it's able to shed some DNA of its DNA into the blood that you're able to pick up on the imaging study, or sorry, on the blood test. And I think that this is why we have to be careful. You say, oh, well, the MD Anderson study only detected HPV ctDNA at baseline in 67% of the cases. The study I just showed you with a different assay was able to do it in 85% of the cases. Again, that doesn't mean that one is better than the other. It just means that maybe perhaps in their study they had higher number of stage 3 patients than we did in ours, or there may be baseline differences in the populations that we're looking at. So I say just some caution before you make head-to-head comparisons. You really can't be doing that until you have the same specimen being split into 2, and the same test is being, 2 different tests are being analyzed on the same specimens. And until you do that, it's really hard to make heads or tails one way or the other. But anyways, we were able to show that that there was a signal between, as consistent with the other studies, between recurrence and the detection of HPV ctDNA. But we were able to look at this and quantify this in a time-dependent fashion. And basically what we saw was that when patients were finishing their chemoradiation, if you looked at the HPV ctDNA, it wasn't able to tell you reliably if the cancer was likely to come back or not. There was no difference in the likelihood for recurrence between the ones with in the red where the ctDNA was detected versus the black where the ctDNA was not detected. So really, really it's not helpful at the end of treatment. However, at 3 months, these curves do separate, and it was very powerful and able to forecast at that initial follow-up period if a patient's anal cancer was likely to come back or not. Those in black here were HPV ctDNA negative, and their cancer by and large was far less likely to come back, whereas those who had detectable circulating tumor DNA, their cancer did come back at that 3-month period. There were some patients who, for one reason or the other, didn't get the blood drawn at month 3. So we were able to look at this in follow-up periods as well. So we asked a question at any point 3 month or beyond, were there, how does this hold up? And we saw the same thing as well, that the assay was very strong and powerful and able to prognosticate whether or not the ctDNA was the cancer was likely to come back according to the ctDNA status. We also collaborated with some gynecologic radiation oncologists who use the same assay in cervical cancer patients at MD Anderson as well. They saw exactly the same thing, that if um, if you look at this at the end of treatment, it doesn't forecast well at all. But if you bring patients back at 3 months and analyze at that time, the data holds up. So it was really nice to kind of see our findings validated with the same exact assay in a different population of patients whose cancer is also predominantly driven by HPV infection as well. So one of the the buzzwords is kind of tumor-informed assays. So I'm going to get a little bit of data with that. This is data from Memorial Sloan Kettering and Moffitt Cancer Center, where they collaborated with Natera. They used this tumor-informed approach, which I talked about earlier, sequencing the tumor for mutation identification, creating a personalized assay for that patient, and then checking the blood to see if you can detect it according to the mutation status for these patients. And again, this is work that we had published, 7 years ago, and Foundation Medicine had also reported that these are cancers which are not characterized by large numbers of mutations. So again, I think we have to keep that in mind as we're thinking about how we're going to answer and what assays we're going to use to answer the questions we want to ask for our patients. But again, in low mutation burden, and unfortunately not a lot of great targets that have drugs that can kind of counteract these mutations that we see. But again, what they saw was that about 2/3 of their cases, the patients had stage 3 anal cancer from the MSK cohort. And in those patients, Natera, to my understanding, their threshold for detection is what they call an MTM level of 0.30 or above. And as you can see here, the stage 3 patients, had higher, MTM ctDNA levels than the stage 1, stage 2 patients who had much lower levels as well. And again, their data, which was presented at ASCO last year, were similar to what we had seen, is that there is clearance of the circulating tumor DNA with chemoradiation. They, in this presentation, did not report the association with survival, which ultimately is the most important. How is the patient going to end up doing? But we really are excited to see this data mature and get out there to see how that associates with survival as well. So we've talked about some of the methodologies. We've talked about the fact that when you have detectable circulating tumor DNA, this indicates that likely the cancer has not been cured, and there's cancer that's left behind. So the question is, what do we do about that? The issue is, if they're negative, if the patients are positive, are there approaches that we can do to escalate their therapy and hopefully cure more people? But likely, on the flip side, patients who are going to be cured, is there an opportunity to potentially de-escalate therapies if they're ctDNA negative, and spare patients the toxicity of curative intent and treatment. So I think that future trials will look at that question. But I think when we're talking, doc, like I have a positive ctDNA result, like I need to do something. I think there are some questions that we still need to ask and think about. So we know the cancer is likely present, the ctDNA result is positive, but we don't know exactly where it's coming from, right? So one question we've had recently come in the clinic is, I finished my chemoradiation, my ctDNA is positive. Can I just go ahead and get my surgery and get the permanent colostomy, which is going to require permanent colostomy? I don't care. Just give me the colostomy. I want my ctDNA gone. I want the cancer gone. That's a very understandable sentiment from the patient. The problem with that question, though, is that in patients with colorectal cancer, when you detect circulating tumor DNA, oftentimes you're seeing early distant metastatic disease, right? So I would not want to subject a patient to, a salvage surgery, to a placement of a permanent colostomy because their ctDNA was positive, when it was never going to come back in the anal rectal area. It was already just present in the liver. Patients, are going to be living with that colostomy for the rest of their life, and you really haven't, I would argue, helped them with that. So we have to think, yes, that we don't know where exactly it's come back, and we certainly know that in patients with colorectal cancer, where comes back. Influences whether or not you're likely to detect circulating tumor DNA. So in patients with colorectal cancer, if they have liver metastases, the circulating tumor DNA, picks that up 95% of the time. But if you look at lung metastases, the patients may have like lung metastases that are clear and present on the CT scan, but the ctDNA is positive only just over 50% of the time. So the site of disease matters as well, because it influences whether or not the currently available ctDNA assays are able to detect that on the blood test. So, we have to be thinking about these kinds of questions before we, rush to potentially unhelpful surgeries, because that's a major quality of life issue. But you could also ask a question: I have detectable circulating tumor DNA. Can you just give me some more chemo? I just finished chemo radiation. I just want some more chemo. And I think we need to have caution about that as well. There was the ACT-2 study. This was a trial that compared 5-FU cisplatin chemoradiation with 5-FU mitomycin chemoradiation. But then after that, patients got additional chemotherapy versus surveillance. And there was no benefit whatsoever in these higher risk clinical patients with additional chemotherapy. So we don't have great data yet that adding chemo beyond chemoradiation cures more patients with anal cancer. What it certainly can do is cause, neuropathy and other side effects as well. So I think that we have to be mindful kind of these side effects. And if we don't have clear signal that this is an effective treatment in curing more patients at this point in time, we have to be very judicial about using chemotherapy just because the ctDNA result is positive. There are trials which are ongoing. I want to highlight Dr. Lakshmi Rajdev, who, and congratulate her for completing the EA2165 trial. This is a trial looking at high risk stage, 2-3 anal cancer, where patients got their chemoradiation and then were either randomized to observation, kind of standard of care, or immunotherapy after chemoradiation. This trial we hope will read out in the next year or so, but there will be analysis of clearance of HPV ctDNA with immunotherapy. I think, because of, most of these patients, the majority of patients are still going to be cured by chemoradiation. It's going to be a low number of patients who are ctDNA positive. So I don't think that we're going to be able to get a definitive answer from this study of whether or not immunotherapy is effective in clearing patients' residual HPV ctDNA after treatment. But I think we should be able to get some initial signal that can help guide further directions. We also asked the question at MD Anderson, again, how can we, inform on the biology of patients with anal cancer? And I really want to highlight Dr. Mir Lim, who's one of our first-year all-star medical oncology fellows at MD Anderson. She'll be presenting this data in San Francisco next month at ASCO GI. But she was able to show that patients who go for surgery and have immune activation signatures in their cancers which are not cured by chemoradiation and removed at the time of surgery, that these patients who have tumors with immune activation signature are more likely to be cured than patients who don't have this immune activation signature. So if you think about that and say, okay, patients who go to surgery, they're not cured by chemoradiation. These are the same patients who were probably most likely ctDNA positive when they finish their chemoradiation. There's a population of patients who are, we could postulate who are going to be HPV ctDNA positive, who have this immune activation signature. And we know in other cancers that patients with immune activation signatures are more likely to benefit from immunotherapy. Can we use immunotherapy to treat HPV ctDNA positive minimal residual disease and hopefully clear potentially this population of patients of their residual cancer and cure them, and secondly, prevent them from having to have a permanent colostomy? So I think that this provides some interesting rationale to look at that. One marker that we've been interested in is a marker called TIGIT. And so we have leveraged this biology to design a trial which will open at MD Anderson in early 2025. This was led by my fantastic colleague and friend, Dr. Emma Holliday, looking at patients with stages 1 to 3 HPV positive cancers, including anal cancer, who are HPV CTA positive at least at this 3-month time point after completion of their curative intent therapy, and have no evidence of any residual cancer on their imaging studies. Patients will receive all patients, no randomization. Everybody gets a combination immunotherapy with this atezolizumab drug, which targets PD-L1, and tiragolumab, which targets TIGIT. And to our knowledge, this is the first clinical trial to intervene in the world on an HPV ctDNA positive result to hopefully cure more patients. So very excited about this. It's taken many years, which kind of comes to my final slide is, I think that one of the joys of getting to be a doctor who takes care of patients with anal cancer is in a place like MD Anderson, you get to meet the most amazing people from around the globe. And you really get to face these patients, face to face, meet them, and just hear their stories and hear their lives and grow to know and love them. And you want to, of course, do everything you can to help each and every patient who comes in your clinic. And it's sometimes been a challenge, I think, to get pharmaceutical companies on board with rare cancers. So we've always kind of taken this this approach from borrowing Kevin Costner from Field of Dreams, that if you build it, they will come. And I just want to say I'm so grateful for people like the Anal Cancer Foundation who have been so passionate, as well as just the amazing patients and supporters of research who have helped us to bring, develop these cutting edge technologies and ultimately bring these to our patients. So that's kind of, I think, summing up my talk. I know I've gone a little bit over time, so sorry about that. But I just want to highlight our wonderful team at MD Anderson, and specifically the HPV Moonshot team, with our team of scientists and faculty members who've been phenomenal to work with as well. So thank you so much. I'm happy to take any questions.
All right. Thank you so much for that really fascinating talk. I learned a lot, and I know our audience did as well. We did have some questions coming through the chat and the Q&A, so I will try to summarize those questions here. There have been some questions about surveillance, using ctDNA in surveillance, and how often it should be used for people that are many years out from treatment.
If a patient is in general years out from completion of their curative intent treatment, the likelihood that the cancer is coming back is very, very low. We know again that the majority of patients with localized anal cancer are going to be cured by chemoradiation. So if we're talking 5-6 years out, I would argue that it's probably not necessary, just by virtue of the fact that if the cancer was going to come back, that it already would have done so, and that patient is already at high likelihood for cure. So I in general, at that point in time, years out, we're not incorporating this into our follow-up for our patients, but also because patients are graduating by that point in time to our survivorship clinics.
Okay. Thank you for clarifying that. Another question that's come up is cost. How are these generally covered by insurance, or if they're not, how are patients paying for these new tests?
Yeah, I think that's to the best of my knowledge, there's not a ctDNA assay which is approved by Medicare specifically for surveillance in anal cancer. When I was kind of updating my slides this weekend, it looks like NavDx's assay is available for HPV positive oropharyngeal cancer, but to my best knowledge, I have not seen that it's approved for any of the anogenital cancers. So there is, that concern that there's a very, real potential that insurance providers, would not cover it if it's ordered today. But I think the other question is, and this is just kind of in general for any test that we order in medicine, a basic chemistry test, a CBC, any test. If you order a test, you really need to know what you're going to beforehand, what you're going to do with that result, whatever way it comes back. And, I think, our challenge to this point has been that if I order this test and I detect ctDNA in a patient with anal cancer, what am I going to do? How am I going to treat that patient? How am I going to take care of that patient? And we get a lot of these questions from outside oncologists, in the community, who call us at MD Anderson and ask, like, oh my gosh, I have this patient with anal cancer. They're a year out now. Their test is positive. What do I do? And this highlights the fact that we don't have therapies which have been proven to clear the ctDNA, which is why, again, we've been so passionate and are excited to bring clinical trials like the one coming to MD Anderson to our patients to help better answer this question, not only for our patients but for the larger population, more importantly, out there.
Mm-hmm. Okay, great. Thank you. And can you touch again on HPV ctDNA versus non-HPV ctDNA?
But I think that, what you want is a test that can tell you whether or not the patient truly has cancer that's still there or not. When you're talking about anal cancer, over 90%, 95% of cases, 95% of the time, these are HPV positive tumors. So like it's built, like there is a clear target that you can, uniformly detect and assess, across, the entirety of the HPV positive patients pretty quickly and pretty easily, without having to send their tissue off for sequencing, and things like that. The problem is as well, there's just not as much tissue available. Oftentimes patients are coming to MD Anderson, for example, with just, one shell of a biopsy that was done, by their outside doctor. These patients aren't going for surgery where you have these, larger tumors where you say, okay, I can take a block of the tissue and send that off for sequencing and creating this assay, like I can do in breast cancer or colon cancer, these other solid tumors. It's usually just, in general, a smaller piece of tissue is not being cured, obtained from surgery. Quick answer is the majority of cases are HPV positive, and it's readily proven. It's very easy logistically to do it, less cumbersome, and you're getting really strong results.
Got it. And then it sounds like for those cases that are non-HPV positive anal cancers, there's still potentially opportunity for tumor-informed testing, um, but you did mention the limitations of limited tissue as well.
Yeah, and I think that there are assays out there which don't require tissue for mutation calling. So I think it is possible that, an assay which incorporates both HPV as well as, mutation calling. You don't always have to have tumor tissue for that. Depending on the assay, may help improve the sensitivity and better capture some of the patients who have HPV negative tumors as well.
Okay, thank you. There have also been a few questions about how this ctDNA testing compares to other tumor markers such as CEA that our community may have had before the CEA test.
Yeah, so we had a fellow look at CEA several years ago in our patients with metastatic disease with anal cancer and didn't find it to be as reliable as a biomarker as opposed to, say, colorectal cancer is. But even with that said, when you look at colorectal cancer, ctDNA is much better at prognosticating, is far superior at prognosticating whether or not a patient is likely to recur versus CEA. And this is also true for other clinical and pathologic features as well, a T stage, nodal involvement, other kind of historically like high risk factors. ctDNA knocks them all out of the park. It appears to be superior to all of these other historical precedents.
Okay, thank you. You also had mentioned that the technology cannot currently identify the site of recurrence anatomically, whether it's, you said the lung has, maybe the liver is more detectable. Do you see in the future that ctDNA technology can identify the site of recurrence?
It's an interesting question, and we have funding for the moonshot to start interrogating that question. Yeah, it's a really interesting question. But as of today, no.
I'm just going to look through a couple of the other questions and try to summarize them as we have a few minutes left. Patients that start out with are initially diagnosed with metastatic cancer, what is the role for this technology in monitoring patients with metastatic disease?
And I think that it's probably heading towards something where, like with a CEA, trends in changes can associate with, with whether or not the tumor is shrinking back or not in the metastatic setting. But again, I would just caution that it's never been 100% perfect. So sometimes patients can have what we call a mixed response. So some of the tumors shrink, some of the tumors grow. If you think about that, like the shrinking ones, you would expect the ctDNA to decrease, but in the growing ones, it would be increasing. And could that cancel its kind of self out? So you don't, I imagine that it's heading in that way. And we certainly we need a marker for patients with metastatic anal cancer where we can reliably track, what's happening in the blood. But I don't think it's ready to go live yet. But I think the question is an excellent one, and I do foresee that this will be soon incorporated into the management of patients with metastatic disease.
There is a question in the chat about specific numbers of ctDNA, that if it's quantified, sometimes it's generally reported as positive or negative, or sometimes there's a number associated with it. How important are those numbers, and how significant are they in the overall picture of the patient's clinical course?
Yeah, I mean, I think that's a really good question. I think that it's a very important question that's actually being asked, because it really highlights the fact that each of the different assays, they could all be HPV ctDNA assays, for example, but how they report out are different between each of the different assays, and what the threshold is for calling detected versus not may differ as well. So again, you can't, extrapolate one from the other. You have to, ask what assay is being run, and what are the specifications of that. In general, as a general rule of thumb in solid tumors, when the number is higher, that oftentimes signifies either a larger tumor burden or a tumor that's dividing more quickly, in the blood, and just dying off, releasing more, growing more, dying off, releasing more. So it can be either of those situations where you see that.
There was a question that came up about false positives and negatives. I know you did mention that in your talk. And how common are those false negative and false positives?
Again, it depends on the tumor type. So sorry, it depends on the assay that's being run. I think that in general, the rates of false positivity and false negativity after treatment are pretty low. There is, a fraction of patients, kind of as I referenced earlier, who have just been diagnosed, who haven't had any treatment, um, who where you may not detect it, so you can get a false negative with the ctDNA there. And again, that may be a reflection of lower volume of disease.
I see. Thank you. And a question that actually just occurred to me as you were mentioning is, um, if a patient was to receive the ctDNA test while on chemoradiation, would that be expected to be having more shedding as the tumor is being radiated?
So I think like with our assay, um, we d don't we didn't see that there was benefit of checking that at the end of. And I think probably, how we rationalized that was, um, the not only are the tumor cells getting, busted up by the chemo radiation, but other, cells kind of in the GI tract, the skin, wherever are also getting affected by the radiation. And that causes a lot of kind of like dust and noise.
Mhm.
That happens, it may dilute down the effects of the ability to detect the ctDNA, the tumor specific DNA, because there's so much noise, surrounding noise from all the other, inflammation. So I think that's kind of how we rationalize why we said we don't feel, with, currently available assays that checking at the end of treatment makes a lot of sense, with,
Mhm.
say that we're pretty confident in from MD Anderson. But with that said, these assays will hopefully evolve and change over time. I don't think that it's going to affect the how we change our management and care of patients
Mhm.
that, based on that result at the end of treatment. So that's why we've, not been inclined to pursue it at that point in time.
Yep. All right. Well, we are at a little bit over time, so we are going to wrap up the webinar. Thank you so much, Dr. Morris, for your time and your really insightful information about this technology. I know this is super interesting to me and many people in our community. We will be posting this webinar on our website, so everyone stay tuned for a link to that. And I did want to again give a special thanks to our sponsor, the Farrah Fawcett Foundation.